remind you all that when we come to a diagnosis, septic shock is not adequate. Where is the anatomy? What is the pathology? And what are potential etiologies? So not just sitting with Burkholderia, TB, spondylitis mediated, other gram negative. So that will make you think along the process. Over to you, Nithish.
Sure. So good morning. I'm presenting a clinical meeting on behalf of Medicine 5. And today's topic is murmuring mind. So start with the clinical scenario. A 50-year-old female is actually brought to ED by her family members. When she presented to ED, she was in a non-verbal state. She was in awake, vacant stare, inattentive, and minimal response to call. And her family members noticed that she was repeatedly picking the bed sheet and trying to catch things in the air, which is not actually in the real thing. And also they've added that she also have a history of fever one day prior to this presentation, along with volume, small volume watery loose stools was happened 10 days before. So based on vital signs, she was, when she came to ED, and she was tachypneic, and her temperature was 100. She was febrile, and her GCS was E4. E4, the patient was awake. The patient was awake, but she was staring, and verbally V was 2 and M was 5. And when we noticed, she was mumbling to herself and picking objects from her, picking at bed sheets and IV line. Those things and all they were doing that. She was doing that time, and she was not oriented to time, place, and person. Central nervous examination wise, a higher mental function we couldn't be able to assess. Cranial nervous examination, second cranial nerve shows a bilateral pupil sluggish and reacting to light, and 3, 4, 6, and 9, 10 were unremarkable. Other systemic examinations were normal. So the past history, patient is a known case of a diabetes mellitus for past 3 years. So a 55-year-old female who actually presented with confusional state with a prior history of a fever, with a 10 days history of a loose stools, and the clinical syndrome that we considered as a unresponsive wakefulness was a post fever and gastroenteritis. She was awake, but she was not. She was aware, but she was not oriented to time, place, and person, which was happened, which was actually preceded by the fever and the acute gastroenteritis. So the differential that we considered could be infectious causes, acute undifferentiated febrile illness, dengue encephalitis, complicated enteric fever, cerebral malaria, and scrub encephalitis. And septic encephalopathy also we considered, would be a pyelonephritis or GNP sepsis, and CNS infections like viral meningoencephalitis. Metabolic causes could be secondary to her GI loss, could be a hyponatremia, hypocalcemia, hyperglycemia, hypernatremia, and hypercalcemia. And structural causes like cortical stroke, since she was an altered sensorium state. You're thinking of any cortical involvement is there or not, a thalamus involvement, and the reticular activating system. So her initial investigation shows leukopenia with a eosinophil count of 0, means eosinophenia, along with LFT shows a mild transaminitis, and the urine routine shows a normal. So since when the patient is actually presented with the fever with altered sensorium, we thought of meningoencephalitis. So we did a lumbar puncture, and the CSF shows a normal protein and glucose. We sent it for the multiple viruses that also came out to be negative, and the other acute undifferentiated febrile illness workup such as dengue, scrub, and malaria came out to be negative. In view of structural causes, we did a CT brain, and that shows no acute neuroparenchymal abnormality. So we did a blood culture, and that blood culture came out to be positive for Salmonella typhi, and the Widal test shows 640 for the Salmonella typhi H. So the diagnosis we considered enteric fever with the coma vigil. So this patient who presented with the altered sensorium, which was preceded by the fever, and her presentation was mumbling to herself, and she was like catching something which was not real in the air. She was doing something, so that we considered it as an Salmonella typhi with the coma vigil. So I just want to discuss about coma vigil, which is nothing but a neuropsychiatric manifestations of typhoid fever, which is actually happens after 24 hours of a fever. So this patient was actually a peculiar stupor with open eyes, but awareness was completely absent. We called it as a muttering delirium, also called it as a typhoid toxemia. So the prevalence was actually 2 to 40% of our typhoid patients globally, and 27% of the typhoid patient can be seen. It was article shows the 27% of typhoid patient in India shows these neuropsychiatric manifestations. So why what is the pathophysiology? Why the patient typhoid bacteria may develop encephalopathy? So this typhoid toxins will disrupt the blood-brain barrier, so that the patients will develop an edema, and finally the patient end up with the neuropsychiatric manifestations. So just want to discuss about the difference between a coma vigil and the delirium. So if in a patient with a coma vigil, the patient will have a awake state, but the patient is not oriented to the time, place, and person. She was completely unaware. But in contrast to that, delirium patient, the patient will be in impaired awareness, and there will be a fluctuating level of a consciousness will be there. In coma vigil, you can see in a patients with a typhoid fever, or in a severe sepsis, or in a traumatic brain injury. Delirium also can seen in a severe sepsis conditions. So these two words I want to elicit. One is the morphology and the flocculation. So the morphology is the definition shows that the picking at real objects like bedcloths, sheets, and threads, which was actually our patient had this symptoms. And flocculation is that picking up the imaginary objects in the air. So this morphology and flocculation are not a specific signs of a typhoid, but it could be a specific signs for diagnosing a coma vigil, and the specificity shows of 98%. So once we diagnosed it yearly, we can prevent the mortality rate. So because that it was the double the of a mortality when compared to the patients with the delirium. So the neuropsychiatric manifestations of the typhoid fever, one of the most common neuropsychiatric manifestation is the, as we discussed, is a coma vigil, and the other neuropsychiatric manifestations such as Parkinson's syndrome, which was actually complicated by the typhoid fever, and schizophrenia psychosis. Though it was very less frequency in the neuropsychiatric manifestation of a typhoid, but the mortality rate was very high in these two conditions compared to the coma vigil. So why typhoid bacteriemia patients who develop encephalopathy? So I've taken an article, and these are the risk factors that could end up with the patients with encephalopathy. Here, the patients with 10 to 24 years of age group will have a high risk of developing encephalopathy, and the patients who are from the slum area will have a increased risk of encephalopathy, and the patients who are in a severe dehydration state, the patients who have a tachypnea, and the saturation was very less, and the WHO titer is more than 160, more than 640. So these are the risk factors. The patient who are having a typhoid fever will end up with the encephalopathy. So the other atypical presentation, usually typhoid fever will presents with the fever, vomiting, and diarrhea. Other atypical presentations such as encephalopathy, which is usually elicited in the first week, and isolated hepatomegaly, pneumonitis, bone marrow depression, and dysuria with normal urine examination in the absence of fever. So diagnosis, blood culture is the most commonly used method. Other cultures will be other diagnostic method will be the bone marrow cultures, and other thing a full blood count and agglutination test, standard agglutination test, but that was a low sensitivity and low predictive value. So the treatment for the typhoid encephalopathy, ceftriaxone, so which was the first line treatment for the patients with typhoid encephalopathy. And the extremely drug resistant typhoid patient, we can consider a meropenem and azithromycin. So hydration is the one of the best, one of the most important treatment for the typhoid encephalopathy. So this is an article which was done in Pakistan. They were comparing the meropenem and azithro. So who are the patients who are having a extremely drug resistant typhoid bacteremia. So the meropenem, they have done a 3 treatment groups. So the meropenem group around some 20 people. In that 20 people, it shows 100% of success rate. Azithromycin shows 11 of around some 50% shows a success rate. And the combination of both meropenem and azithromycin shows a 35%. So there is no much difference between these three each treatment groups. So combination of meropenem azithro would be the preferable for a patients who are having extremely drug resistant typhoid bacteremia. So for our patient, so she actually presented with headache, fever with altered sensorium. Considering a meningoencephalitis, which initially started with ceftriaxone and vancomycin, and we actually then she was improved. She was actually improved later, and sensorium was improved. Then we stopped, and the CSF cultures and the PCR came out to be negative, and she was sensorium was improved. We stopped the ceftriaxone and vancomycin, and then we changed and we put her on with azithromycin 1 gram, and the blood culture finally came out to be negative. So the take-home message is patient when they are presenting to the ED should differentiate the coma vigil with a delirium. So this patient was actually was awake, but she was not aware. She was not oriented to the time and place and persons. So when we can able to elicit yearly in a coma vigil state, we can able to initiate the antibiotics yearly, and we can prevent the mortality rate.
Thanks, Nithish. Any questions or comments?
We have seen this case in the ward. I just want to say our highlight of the presentation just to show this clinical symptom of muttering delirium. How we can differentiate it from what we call a delirium altered sensorium. So from ED also they have discussed the saying it was a fever with altered sensorium, so meningoencephalitis. But actually the patient is awake. The difference between that's what we want to show. It's not a delirium or altered meningoencephalitis symptom. It's just like a patient is awake, but inattentive. There is no attention. He's not responding to us, but it's not a florid delirium. So that's what we, and there are typical features, what we said, cardiology and flocculation. We couldn't get a video of it. She was actually picking of beds, picking at the bed sheet, the pillow, the restraint bands. Then she was in between picking on the air. So this is also very classical. There are very few literature case reports only we had found which had shown these typical symptoms. Once she got little better and she started responding to us, she started saying she had hallucination of objects coming to kill her. So all these are very classical of something called coma vigil. And coma vigil, again, it's not typhoid delirium. Coma vigil, it's a syndrome which present like this, can be seen, mostly seen in typhoid, but a lot of other severe sepsis, pneumonia also. And again, one mistake I think was coma vigil is not the most common neuropsychiatric manifestation. It's just altered delirium. This is one of the manifestation of severe typhoid or typhoid toxemia. So our highlight was just to show that how to differentiate delirium versus coma vigil versus a delirium. Like you shouldn't call it a delirium. The patient is actually awake, but she is mumbling to herself some soft word she is coming out.
Any
from
other
her.
thoughts on that? I kind of beg to differ on that concept.
Just a couple of things. Sorry, no.
Yeah,
Go ahead. No, I just go back to your slide on that studies that you showed. The most important part is what you didn't highlight.
Yeah.
That study that you showed with the
Neurological.
come down on the data. See, one of the things that I don't want the postgraduates going back and thinking is that 1 day history of fever, typhoid, coma. No. Why do you think he's got only 1 day history of fever? Did you go back on the treatment history? Just go back to the next one. Yeah. Where was that data? Come down. Yeah, just hold there. Yeah. So why do you think that the person had only 1 day history of fever? All that one number, this is from India, so it's a bit of a problem. If you don't take a good treatment history, you'll end up with a 1 day history of fever. Because invariably, what happens when the patient has fever in India, very unlike the West, they go to the pharmacy and what they get is paracetamol, Dexa, along with the antibiotic for good measure, multivitamin, and a PPI. Okay, and who dispenses it? Not the doctor, the pharmacist. Okay, so it's always important to go back and say, what all tablets have you taken? When did you first take the tablets? Okay, that's when you get this 1 day history of fever. Usually you get, this is classical behavior. We used to see this a lot when we were training 20 years ago. And this is a common presentation when it is late. Look at the duration. Okay, the mean duration they found was about 7 days is what they've said here. Okay, it's usually in the second week. Remember, whether it is scrub, whether it is typhoid, the complications happen after 5 to 7 days. Doesn't happen in day one. Somebody comes with day one history, 1 day history of high spiking fever, altered sensorium, by all means think viral and meningoencephalitis. But if it is not, it's not a 1 day history, please go back and always take the treatment history. Complete history gives you good diagnosis. Okay, so 1 day history, typhoid vigil, I will go back and look at the treatment. Okay, because they don't come with 1 day history. The fact that it is 10 days of GI manifestation tells me that she must have had something, and that's the reason why she's come with this. Okay, and this is classical. If you've ever seen one, you'll never forget it. They pick at the bedclothes, they pick at things. I really wish you had taken a video. It would have been such a it would be very informative for you guys. The other thing that's happened is that azithromycin, when it came in, remember everyone takes azithromycin the minute there is a fever. We've not had typhoid coming into the hospital for many years. Now that the MIC2 azithromycin is probably creeping up, we are getting to see more typhoid. Okay, and the reason they come is not because they are old or young, it's because they are in the slum that they come with encephalopathy, because they don't have the means to come to a good hospital and get the right treatment. Okay, so those are the reasons why patients don't land up early enough. It's not the age or it's not the thing. It's if they have the means, they come get treated correctly and early, they wouldn't get into this state.
Another thought for the registrars interns is, rather than